Manoj, you start.
So a very good evening and welcome you all for this episode of Young Surgeon Forum. As you already witnessed the first webinar by the ANMOL series, a very unique initiative which has been started. Dr. Vasudev Gadegone, who is a MOA president, it was his basic idea to have this kind of interactive session from the young orthopedic surgeons. And here now all the female orthopedics from all across Maharashtra as well as few from the India will be participating in this webinar. So today we will be having the second in the series of ANMOL. We will be having the various challenging cases presentation by various young orthopedic surgeons. For the brief welcome, I will ask Dr. Vasudev Gadegone to have a few words about this today's webinar.
I, Dr. Vasudev Gadegone, President of Maharashtra Orthopaedic Association, welcome all members of Maharashtra Orthopaedic Association, Indian Orthopaedic Association, and viewers of the OrthoTV all over the world. This is the first time in Indian history that ANMOL Women's Wing started their webinar, and this is the second webinar. We started first webinar in the month of March, and this is in the month of the May. Probably we may have a next again a third webinar of a women's wing. Nowhere in India this type of a project is carried out, and I am proud of the Maharashtra Women's Wing. And there are so many stalwarts here. They are not lagging behind, and they can also produce a good work, and they can also present. I want to give a chance not only to the veteran surgeons, but to young ladies who are budding and carrying out their work best in their capacity, and they must be exposed to the wide variety of the presentation. So thank you very much, and this will be the benchmark in the India's history, and I congratulate you all. I cannot name, but the Neha is the person who has started this with the Rujuta Mehta, and today we are having a very senior members of Asami, Kulkarni madam, Aiyer madam, Binoti madam. I welcome you all, and also I am very thankful to the OrthoTV, Ashok, Shyam and Neeraj Bijlani for giving us a chance to present the work of our young orthopedic surgeons of the women wing. Thank you very much and best of luck.
Thank you.
So I now ask Dr. Neha Godghate, who is the convener for this today's ANMOL series webinar second episode, to start the proceedings.
Yes. I would like to invite Dr. Binoti ma'am to say a few words as a voice member.
Yeah. Thank you, Neha, and thank you, Dr. Gadegone, Dr. Manoj, who have been the backbone and constant encouragement for our venture. As you all know that the number of women orthopedic surgeons are increasing day by day in India. And I think this is the first of its kind where, Maharashtra Orthopaedic Association and President Dr. Gadegone has given us so much encouragement and given a special webinar for dedicated only presentations by women orthopedic surgeons, not just veteran, but young women orthopedic surgeons of Maharashtra and India. So we had a wonderful session, first webinar. All of those who have missed it, I think can go back and see on OrthoTV. And I'm sure today we have another wonderful webinar today. We have senior panelists, Dr. Rujuta Kulkarni and Dr. Sujata. And it is with the constant effort by Dr. Neha that this has been possible to coordinate all of us. So more from Neha, over to you for the details and further proceedings.
Thank you, Binoti ma'am. So today I'm really proud, privileged to host this today's meeting. So today we have an esteemed panelist, Dr. Rujuta Kulkarni. She's a president of Asami, India. She's advisor of IOA Elizarov subcommittee and is HOD at Pediatric Orthopedic Department at Swasthiyog Pratishthan, Neeraj. She has many national and international publications in her name. Our other panelist, Dr. Sujata Aiyer, is a finest orthopedic surgeon from Mumbai city. She has completed her MS Ortho from Nair Hospital and went to UK under the Overseas Doctors Training Scheme. did her FRCS, then returned back to India after 4 years and joined Sion Hospital. She has been trained by our doctors C.A. Talwalkar and Dr. Didi Tanna, who taught her how to analyze many cases. Now, she is an additional professor at KM Hospital, Mumbai. Welcome, Dr. Ruta and Dr. Sujata, ma'am.
Thank you, Neha. Thank you.
Thank you, Neha.
Now, without much ado, we should start with our presentations. Our first presenter is Dr. Binoti Vyas, ma'am, and Binoti Vyas Sheth, ma'am. She is my teacher. She's an eminent pediatric orthopedic surgeon from Mumbai. She has many national and international publications and many chapters in various books. She's a professor and head in orthopedics at Sion Hospital, Mumbai. Yes, ma'am.
Yeah, so thank you, Neha, for that introduction. Can you see my screen?
Yes.
Yes, ma'am.
Yes.
Yeah.
Make it full screen, madam.
Yeah. Yes, yes. One second. Not getting full screen. Yeah, is it visible?
Yes.
Can you see? Yeah.
Yes, yes, yes.
Yes. So today's case is a 10-year-old male child. He was hailing from rural part of India, and he presented to us with pain and swelling in his right forearm with discharging sinus present since 4 months. He did not give any history of fever at the time of presentation. He was afebrile. The only positive history he had in past was that he had some trauma 1 year ago due to fall while he was working in the field. And there was some wound over his forearm, which was managed locally by local doctor with dressings. And then after some 6 to 8 months, he started having significant pain and swelling in the forearm, and he started having discharge. When he presented, he had no pronation supination. His forearm was fixed, and he had elbow range of motion from 20 to 110 degrees. I do not have the clinical picture, but this was his presentation. And when he took the X-ray, this was the picture. So as you can see over here also, you can make out that there's significant soft tissue swelling. There is a big lytic lesion in the intraosseous membrane, which is encroaching on the radius and the ulna, proximal half. And you can see multiple lytic lesions, sclerotic area, and both radius and ulna seem to be fused. So anyone wants to opine on this and as to what is their thought process, what could we be dealing with? What could be the probable diagnosis, or how do we go about further for establishing the diagnosis? Anyone wants to make a quick
What
comment?
was the blood picture?
Yeah, so that is what you would ask for later. So that's what we had done later. But just looking at the X-ray right now, do you want to judge anything, or you would straight away ask for first blood investigations?
Yeah. It seems to be a massively destructive kind of lesion, and
Yes.
it's involving both simultaneously. Yeah, it must have started near the intraosseous membrane and seems to be spreading and expanding gradually towards the both bone and causing the destruction. Acute pyogenic infection previously.
Could be a large foreign body granuloma with osteomyelitis.
So what we were thinking that probably is it some chronic osteomyelitis from the picture of discharging sinus and pain and gradually increasing swelling, or do we were dealing with any tumor, some unusual variety of fibromatosis or fibrous tumor or soft tissue tumor, or is it something like a very rare variety of a big hydatid cyst? Sometimes the hydatid cysts also involve long bones. So this was our thought process. So as Dr. Ruta rightly said, first thing what we ordered was the blood investigation. So his WBC count was raised. He had raised ESR 50 millimeters and CRP was normal. So this picture appeared that we were not dealing anything with acute, but it seemed to be something like a chronic infection. Anything further now beyond this? Now, what would be the next line of investigation?
Pus culture, maybe from the discharging sinus.
Yes. So sometimes, most of the time when you take from the sinus, it's very superficial. So that does not give, and since we had, it was looking like a very atypical variety of any osteomyelitis, what we ordered, we thought we will go ahead with an MRI. So this was the MRI picture showing a large lesion as was seen on the X-ray in the interosseous space involving the proximal half of the forearm, encroaching on both the bones, radius and ulna. There was cortical irregularity with bone destruction. Luckily, there was no communication with the elbow joint. Elbow joint looked quite spared. And also both the physis, radius and ulna proximal physis were normal. So looking at this picture, any one of you can have further clarification, any classical appearance?
Maybe hydrated cyst.
Okay. Why, sir? Have you seen any hydatid cyst like this involving?
There are some, you can see there are so many like loculi are seen all over, and there is a speckled calcification. And that
Okay.
is speckled calcification, and then you can see cyst. You can actually, they're difficult to say if they are cyst or what, but probably it looks like not a neoplastic, it's a benign lesion and maybe hydatid cyst. But hydatid cyst, it requires a very long time, and there must be a history of some, although he is a child, but maybe this is the possibility.
Okay. Any other opinion from any other faculty? Or have they seen such a picture in any time in their career?
I have not seen, but it still go with the chronic osteomyelitis and get a ultrasound guided aspiration first.
Okay.
For me, it seems to be a soft tissue kind of lesion which is expanding and extending across the bones and then compressing and secondarily causing these changes in the bone.
Yeah,
Okay.
even I agree. I think it's a soft tissue lesion rather than and definitely it looks benign.
Okay.
It doesn't look malignant.
So again, like all three have different, one group feels it's an osteomyelitis, one feels it could be a hydatid cyst, the other one feels it's a soft tissue sarcoma. But this is a very classical appearance, which we also did not know that time. But I would tell you, this is called as dot in circle appearance. What you see, those black dots are typical of something which I will tell you later. So these are all black dots, and then there is a white circle. So this is a dot in circle classical MRI appearance of the entity, which we are going to discuss. So again, we were also confused because that time we also did not know such an appearance. We went through later on. So we thought, why not do a biopsy, rather than going straight away by doing just an aspiration, we may not be able to aspirate anything. So take an open biopsy. So we made a small incision for the biopsy, and we were surprised to see that there was this black tissue, which was black granules, which were coming out. So then we extended the incision and converted to a proper debridement. So this whole cavity was filled with such black granules, lots and lots of them filling up the whole cavity. So we could remove so much of black granules, and after removing everything, the bone looked quite sclerotic, but there was no break, and both bones, radius and ulna, were fused. So this was black grains with granulation tissue in that area. So now anything, so this was definitely not a hydatid cyst. It did not look like any soft tissue tumor, but this was something with a black grain osteomyelitis. So any further opinion or any further clarity on this? So this was first time I had also seen such a thing when, draining an osteomyelitis. So we consulted our microbiologist, and they said this looks like a black grain fungal infection. And then they asked to send not only the routine pus, scab and TB culture, but also send for fungal culture and scab examination. So surprisingly, as they had suggested us, the microscopic examination with 10% KOH mount did grow some fungal hyphae. And then we subjected it to culture, fungal culture, and that grew this flat mold with brown diffusible pigment. And this was diagnosed as Madurella mycetomatis. So though Madura mycetoma is seen more in foot, sometimes you can also see it in forearm. And this was further confirmed by doing special mount and special growth. And that again confirmed the diagnosis. So the final diagnosis was made as black grain mycetoma caused by Madurella mycetomatis. So this was the diagnosis, a very unusual picture. I have never seen such a case of a fungal osteomyelitis involving the forearm bone at this young age of child. So now was the next question, like what's the treatment? We had never treated. So again, we took consultation and in collaboration with our microbiologist and the pediatricians, we started the patient as per their advised on voriconazole, 6 milligram per kg per day intravenous for 6 weeks, followed by oral for 3 months, because this requires a prolonged treatment. Otherwise, there are chances of recurrence very high. So we did the proper medical management for this, and surprisingly and luckily, we could achieve a full treatment for this. The operative wound, the sinus, everything healed. The swelling reduced in size, the pain also subsided. But of course, the X-ray picture was not, because we had not filled the cavity, because as recommendation are there, initially you have to get the medical control, get the disease under control, and then after 6 months, if required, you think of reconstituting the bone if there is any big defect or if there is any chance for potential pathological fracture. So the X-ray picture did improve. Some amount of those lytic lesions did improve. The bone looked better. The pain, the swelling around the proximal forearm had reduced. The child was clinically better. But the X-ray, the cavity still remained. So we protected him in a brace. And this were his range, his pronation, supination, of course, because there was radial ulnar synostosis, did not improve, but he had a pain-free range. Whatever pre-op was retained in the post-op picture also. So we went back and tried and find out, because this was the first time for us. This was mycetoma. It's a very rare disease involving the forearm, mycetoma involving the causing osteomyelitis. Over 33 years period, only 482 cases are picked up in this particular center, and of which it is of 2 types. You can have eumycetoma or actinomycetoma. So eumycetoma is only 7%. And mostly happens in agricultural workers in the age group of 20 to 40. So this child, who was also again working in fields, could have contaminated it by some local wound which he had sustained when he had that fall. And from that, he must have incubated the fungus, and then this must have grown. So most of the time it involves the lower limb. The upper limb involvement is only 14%. And it typically presents as soft tissue swelling with draining sinuses, and grains are observed in all the cases. So Madurella mycetomatis is the most common causative agent. So eumycetoma mostly is seen by these 3 common varieties. And if it is black grain, it is caused by Madurella mycetomatis. If it's white grain, sometimes it is caused by some other fungus. And traumatic introduction of infectious agent through skin with contaminated object is the cause, and soil is the natural reservoir. And as per treatment, the medical management has to be first initiated, and that gives good amount of result. But only thing, it's a prolonged course and it has its own adverse effects. So you have to keep the child under observation. So I think this was a challenging case to diagnose, but I think ultimately with the help of the other colleagues and all, we could manage him well. We were planning to keep him under observation and do any interventional bone graft or fill the defect with the allograft, but the patient did not follow up later on. So supposedly, at least he did not have any recurrence. That is what we assume. So thank you very much. So anyone has any experience of such thing or any other comments or anything?
Madam, this is excellent case I have not seen in my lifetime. And this is a wonderful presentation. Last time also you have presented a very wonderful case, and congratulations. And this is absolutely something different. Something different we have presented.
Yeah. Great case, Binoti. We see Madura mycosis quite frequently in foot, but in forearm, it's really, really rare. Yeah, but you have to watch for recurrence, which is quite high. I mean, in foot, the recurrence is very high. So you should keep a follow-up of this child and see for the recurrence.
There is a difference between chronic osteomyelitis with pyogenic and fungal. Fungal, they don't have much pain as compared to the pyogenic or tubercular. So in the fungal infection, they must be having a multiple bleps and discharging sinuses, but functionally, they are not very much hampered as compared to the chronic osteomyelitis infective or tubercular. That is my submission.
And I also have one suggestion that you delay the reconstruction. I mean, so it's a good idea to delay it.
Yeah.
Regarding this, I wanted to ask till what time should we delay the reconstruction? Because if the patient is asymptomatic for a year or so and he wants to regain his functional activities, so till what time you should tell the patient that he need reconstruction?
So in this case, actually, getting a forearm pronation supination is not possible because there is bony synostosis. And as we know, if you excise the synostosis, the chance of recurrence are there. The only worry is that thin bone, which is there lying, if there is a pathological fracture, then it will be a problem. But again, synostosis is helping because both bones are fused. So only if he has, a precarious thing, there are chances of pathological fracture, then we want to increase the bone substance and put some allograft. But otherwise, in this case, as long as he remains disease-free and he doesn't recur, I think we feel that he would have a good outcome.
So what reconstruction you are planning? Just an allograft or bone grafting there in the cavity, or?
Yeah, just around, just to increase the bone mass, that area, because that cavity is surrounded by very two thin bones. But because both are fused, even if probably one fractures, it's like a synostosis. So what we want to prevent is any pathological fracture or anything. So just.
Are you going to protect him with any brace or something for some time?
Protected him with a brace during his work, so that because once they go in field, they do little heavy work. That time it may be a very thin bone and there is a possibility of cracking it. So we protected him.
At what point will you, like when you say prolong and delay the bone grafting, he's 10 years now, at what age or at what point in his life are you going to go ahead if he follows back to do the bone graft?
Yeah, so
the growth spurt is over,
no, nothing to do with the growth spurt, but says this was some other bone where it demanded that requires, then the literature says that 6 months period where he is not, there is no recurrence of infection, he is infection free 6 months, then you can go ahead with and do a bone graft. If suppose it was a humerus fracture with a very thin cortical shell where some other site. In this particular patient, as I'd already explained, I'm not hurrying up unless the patient demands. But otherwise,
to put a bone graft from where?
Allograft, we will have to use allograft in children, maybe mixed with auto allo, because you will not get so much of autograft from anywhere. You'll have to mix it with allograft.
This is a fungal infection we are presenting as a chronic granulomatous kind of thing.
Yes,
what were there any, it's very unusual to have. What were the predisposing factors for this child, and are there any chances of having fungal septicemia? Because he must have some kind of immunocompromised some factors which could have caused for fungals to stay in the body for such a long time.
So in his case, as I said, he gave us a history of fall where we had some wound over the forearm. So from that, soil falling on a ground in a field. So contamination from the soil where the fungi are there. And that must have got in, this particular variety, the chances of fungal septicemia is not so high. In some variety like Candida and all, those kinds of ones, especially in neonates, many times you have Candida osteomyelitis and septicemia. But this one is a chronic variety and the focus was from the soil, so wound over there, which was not properly managed. He must have harbored from there and then that continued.
Unless the child is immunocompromised, I don't think there is a fear of fungal septicemia. Yeah. Was he immunocompromised?
No.
Binoti, it's a good case. At the time of debridement, did you open the medullary canals on either side? Were they blocked or were they open?
No, it was like we didn't try and actually open anything. We just debrided the cavity which was there because we didn't want to, in fact, open it and introduce, because the other bone, even MRI wise, did not show any involvement of the distal half. It was only that cavity which was filled up. So we did not try and extend the debridement in the medulla of the distal half of the forearm. And proximally also there were physes which were normal. So we did not want to do anything there. It was mainly the cavity which was debrided.
Okay. Any other questions? It's a wonderful, as usual, ma'am, very unique cases and
very unusual cases being in Sion Hospital.
Yes, thank you, Binoti ma'am, for that unusual case and adding much knowledge to our brain. Before heading, I would like to welcome Dr. Rujuta Mehta, our moderator for the webinar.
Hi everyone, I'm sorry for joining in late, but there were just some last minute things which had to be attended to. But fabulous as usual, and great to see all the lovely women and new girls presenting this time. And big thank you to Gadegone sir for also including us in the young surgeons. So I think this is one place where we can pass off as young. Thank you, sir. Let's go ahead.
Yeah, our next speaker is Dr. Mitali Mokashi. She is a second-year resident at Grand Medical College and Sir JJ Group of Hospitals, Mumbai. And she is a very enthusiastic academician. So over to you, Mitali. Please share your screen.
Thank you so much, ma'am, for the beautiful introduction. Good evening, everyone. Good evening to all the senior panelists and all my seniors here. I would like to thank Maharashtra Orthopaedic Association and Voice before beginning my presentation for giving me this opportunity to present on such a big platform. Today, I would like to present a case of a giant cell tumor. A 26-year-old female had presented to us in the OPD with complaints of pain in the right foot since 1 year. The pain was insidious in onset. It was dull aching in type. It progressed gradually. It was non-radiating, non-migrating, relieved on rest and medication, and aggravated on movement and activity. There was swelling in the right foot present since 6 months, which was insidious in onset and progressed gradually. The patient was unable to bear weight on the affected foot when she came to us. There was no history of frank trauma, no distal neurovascular deficit, or no comorbidities which the patient had. On examination, there was swelling present over the dorsomedial aspect of the right foot, about 3 into 3 into 1 centimeter in size. It was hard in consistency. Skin over the swelling was free, and a scar of a previous biopsy was present over the medial aspect. On examination of the right foot, there was tenderness present on the swelling. Inversion, eversion of the foot was painful. Ankle range of motion was full and free, and there was no distal neurovascular deficit. We proceeded with getting radiographs of the patient. Anterior-posterior and oblique views of the foot were done. We appreciated an expansile lytic lesion which originated in the navicular bone and was extending into the cuneiform bones. The ankle X-rays done were suggestive of a similar finding of extension into the cuneiforms. We proceeded to do a CT scan, which again to assess the exact extent of the lesion. It originated from the navicular and also extended into the calcaneum. We proceeded with an MRI, which was suggested to look for the soft tissue extension. And surprisingly, on the MRI report, it was suggestive of a possible neoplastic lesion, probably a round cell neoplasm. We then proceeded to a fine needle aspiration cytology, which suggested osteoclastic giant cell resection interspread with small round cells with scanty cytoplasm, suggestive of a giant cell tumor. I would now like to open the case for discussion. What would be the management of this case?
Ruta ma'am, would you like to answer?
So the tumor extended into the calcaneus as well from navicular?
Yes, ma'am, there will. Yes, ma'am.
Quite unusual, actually. Okay, so denosumab might be of use.
Okay, ma'am. Ma'am, would you consider a
tumor.
neoadjuvant therapy or an adjuvant therapy, since it is a young female and
How old is she?
27-year-old female, ma'am.
Okay. So yeah, neoadjuvant therapy might be, a better option.
Okay, ma'am.
Mitali,
And of course, after denosumab, then you might have to go for a definitive treatment and excise whatever is remaining of the tumor, and then you might have to go for a fusion of
okay, ma'am. Ma'am, would you consider local chemical cauterization or bone grafting in this case?
Yes, Of course. Of course. Bone grafting is necessary.
Was the histopath feature suggestive of GCT? Because why round cells? What is the other feature of GCT? It's not round cells.
Yes, ma'am. So this was the fine needle aspiration cytology report which we had received at the time.
Yeah, but
So-
what is the classic picture in GCT?
GCT has mononuclear cells, ma'am. So maybe they were pointing towards that in the fine needle aspiration cytology report.
Any differential diagnosis did you consider?
At the time, ma'am, we had taken another radiologist's opinion, and they were pretty sure that the CT scan and MRI findings were suggestive of a giant cell tumor. But whatever it was, we had considered taking an open biopsy of the lesion and getting a better sample for a better report.
So you took biopsy from where?
Yes, ma'am. So I'm proceeding to the management now. We did
Just
curettage.
one comment, yeah, just one.
No.
Yes,
So GCT of this particular bone which has started, it must have broken away and then it has got the contiguous spread. Very difficult to explain it in the other bones as well if it is only GCT.
Yes,
Yeah,
sir.
especially calcaneus.
Elsewhere the calcaneus.
Yeah.
Exactly.
Yeah, because the classic feature of GCT is the fibroblasts.
Yes,
They
ma'am.
are the tumorous portion of the GCT. It's not the osteoclastic giant cells.
Yes, ma'am.
In GCT is generally locally aggressive. So this has spread to calcaneum. So that again rings a bell whether it is really GCT.
So looks like a very aggressive tumor.
Yes, ma'am. Ma'am, so what we did was we proceeded to curettage with chemical cauterization, with bone grafting, with fixation. So a medial incision was taken. The lesion was visualized. It was curated and cauterization was done with hydrogen peroxide. After that, we went on to autogenic bone grafting and fixation, as Ruta ma'am correctly pointed out. Adjuvant therapy was then given with denosumab. 120 mg subcutaneous was given on day 0, 8, 15, and 28. The histopathology report now, which the sample for which was obtained intraoperatively, was suggestive of uniformly scattered giant cells, osteoclast-like cells in mononuclear stromal cells, which was then confirmatory of giant cell tumor of the bone. Since the lesion was locally expansile, we had considered denosumab therapy in a young female to promote fibrosis. The postoperative range of motion at 1 month of follow-up was acceptable. On review of literature, we had found that giant cell tumor of the bone consists of only 4% of all the giant cell tumors. Reconstruction was considered. A case report for reconstruction showed good results with fixation with a DCP on the medial aspect of the foot to do arthrodesis. In this particular case, they had then proceeded with implant removal at a 1 year follow-up, and the good results were obtained. The denosumab therapy is now an FDA-approved monoclonal antibody. It acts against the rank lesion It acts against the rank lesion so that local recurrence of the tumor is less. Fibrosis is promoted. Thank you.
Excellent presentation, Mithali. Only few things that I would like to draw your attention to is when you go, if you can go back to the X-ray quickly.
Yes, ma'am.
So whenever you get something like this in a young female,
yes, ma'am.
in an unusual location, especially,
yes,
we normally expect it at distal ends of long bones, say distal
yes,
end radius, distal end femur, tibia. But when you get in an unusual location, may be worthwhile digging into the past history, whether there was a pre-existing cyst or an aneurysmal bone cyst which underwent a malignant transformation. So that is one thing to be looked into. And whenever you're faced with an X-ray like this, where something does not fit, it looks out of proportion to what your lesion is showing. Always keep the possibility of a tumor in mind, never dismiss it off as osteomyelitis. So I'm glad that you proceeded with the correct steps that first you did an FNAC, did not violate any tissue planes, and all the pointers were there. It is as good as the navicular had burst out, it had breached margins, it was showing a very aggressive behavior. And then you proceeded with the final listing along with considering adjuvant therapy. So all steps have been fine, but this is just a message to other PGs that whenever you see something that does not fit on the X-ray, always try to look for other things.
Yes, ma'am.
Wonderful presentation.
Great case and very well presented. Good.
Thank you.
She's always been a very enthusiastic presenter, and the case was really challenging. The challenge was itself in a diagnosis. So finally, you got a very good results. Very nice, Mithali.
Thank you.
Any questions for Mithali?
Actually, I must congratulate Mithali because the way in which she has presented, that is more important than the content of the case. Because such an young age, I have seen even a senior fellow, they are fumbled most of the time, but she has presented very nicely. I am proud of you. Keep it up.
Thank you so much, sir. Means a lot.
आणि रुता मॅडम तुमची सून सुद्धा छान प्रेझेंट करते.
Thank you, sir. I'll convey it to you, to her.
So with this, we go on to our next presentation. Our next presentation, she is one dynamic pediatric orthopedic surgeon who has held so many posts by now that it is difficult to mention it in 2 minutes. She is a chairperson of Voice, Bombay Orthopedic Society secretary, a POE Waves esteemed member, and now HOD at Wadia, BJ Wadia Parel. She is an avid academician and passionate teacher. Please welcome Dr. Rujuta Mehta, ma'am.
Thank you, Neha, for really a wonderful introduction. But I mean, only correction I will make is that US Secretary is currently Neeraj Bijlani, who is hosting this. So,
ex-secretary.
Yeah. So although I'm old, I'm allowed a young surgeon's presentation, and which I'm totally delighted about. So is everyone seeing my screen properly? Is the screen visible well?
Yeah. It's well visible.
So this was one of the kind of management challenges which we've seen. As all of us know, stiff elbows and especially myositis ossificans is quite a common problem with children. And sometimes to whether to take this challenge on or no itself may be a big thing, because you may end up being either very foolhardy and do too much and it may recur all over again, or you may just not get the desired result, which leaves you very, very crestfallen. We encountered one such myositis ossificans, which was probably the worst I would have seen in all these years, because it looked as if there was just no way. And parents were terribly keen because she was a girl. They had brought her all the way from the interiors of Jharkhand, and they were extremely keen that whatever you do, as long as she's even 10% better from where she is, we will still want to take that risk. So let's look at what had happened to her. She was an 11-year-old girl who was brought with complaints of complete stiffness of the left elbow since 2 years, so about a long standing. When we dug into the history as to what had caused this, there was trauma to the left elbow treated elsewhere with a close reduction and slab just in the OPD, which means a lot of manipulation would have happened in the first place over there. They pulled out one old X-ray, and this is all we managed to see. So clearly this was a grade 3 supracondylar, something which should have been ideally treated with a close reduction under GA, which would have been either gentle or assisted with one of the maneuvers that you would use for a difficult supracondylar. And nothing of that sort had been done, and a very reasonable alignment they had managed in OPD. So I can just about imagine how much pulling, pushing must have gone on. And just for the benefit of the audience, there are some videos floating around on YouTube where I'm told where this is being marketed as a specialized technique, where the patient is made to hang the hand below the bed virtually from the shoulder onwards. And they say that we're using gravity, and then about 2 people just hold the patient from the shoulder and suddenly a yank is given. So that kind of technique should definitely not be followed, because you can end up with a great soup, as you will see now. So what happened to this young lady? This is where she was. She was stuck in a FFD of 40 degrees. absolutely zero movement, maybe about 10 degrees, as you can perhaps say here. There was a complete bony block on both sides. She was in a fixed supination deformity of 80 degrees, which is a very bad position to fuse in. Luckily, there was no distal neurovascular deficit, but the parents were insistent that we have to do something about this because she simply even cannot get hand to the mouth. There was a lot of difficulty in activities of daily living, and they were worried that since she's a girl, when she grows up, she's going to have gross problems. This was the initial X-ray. Then when we looked into what had happened, so you can very well see that the entire new bone formation has started enveloping the fragments over here, especially the proximal fragment, which tends to buttonhole through the brachialis. And you can see that. So this was all on retrospect wisdom. And we realized why all this has happened. And I'm taking it in sequence, but that is not how she had come to us. She came just with a bony ankylosis. And that is what she came to us with. If you can really look at this, this is a complete bony bridge right from the humerus to the ulna. If I can show you on the lateral view, absolutely nothing to discern where the humeral shaft ends and where the new bone formation begins. So this is pure lamellar bone, very, very well woven, totally mature myositis, and which to my mind then meant that means the entire brachialis is probably involved with it, maybe along with the neurovascular structures as well, which although not affected with a deficit, may be entrapped because there is hardly any soft tissue cover, if you see here, between the bony mass and the skin. So after thinking what shall we do, we first decided that we must investigate and we must absolutely delineate as to from where to where this is really extending. So we did a CT scan with a 3D reconstruction to map out the exact anatomy because we were keen to excise it. Now that it was mature myositis, it is okay to attempt excision, provided you can really do it with safe margins. Yeah, so we looked at it. It was a thick bony bridging of the entire brachialis muscle. Radiocapital alignment was good, as you can see in some of the plates here. The ulno you can get an inkling that the radiocapital alignment is all right. And it is involving only the ulna and the humerus. Here again, you can see the radial relationship is fairly good, and that there is scope for some joint movement over there. The mass was blocking the flexion, and it was basically difficult for her to do pronosupination, but I was expecting a reasonable joint over here. So prognosis of getting a future pronosupination, at least some amount of pronosupination, was good. So that's the CT scan pictures. And then we also did an MRI because it's not just the bone, but even the soft tissues that we needed to outline. And here we saw that the joint actually inside was fairly well maintained. Especially the radiocapitular joint was very good. There was healthy cartilage. There was absolutely no other problem. So as long as we are able to take this away en masse, it would have been acceptable. And this was the neurovascular bundle totally plastered to the myositic mass. So what were our challenges? If I were to list them, there's a huge bony mass from the humerus to the ulna. The bony ankylosis is already long-standing. Margins would have been a little difficult, and the neurovascular anatomical status was difficult to preempt as to where exactly in that mass it is entrapped. So therefore, the risk of surgery during the dissection was high, and we had to take preventive steps to ensure that we don't have a problem on table, or at least there is a vascular surgeon ready for anastomosis. If we do this, and there's always a chance of reformation, so the decision where how much to excise for an orthopedic surgeon, I think that's very important, whether to do too much or to do too less. On table, one ends up being very greedy, and the more we excise and the more we see, sometimes we really tend to go on, and then that leads to refractures in future. So to strike a balance will be the right thing, as to just do enough to restore some range and make sure that we don't end up with path fractures later. And if you do too less, the patient will not be better. So we had counseled the patient already that this may happen. At the same time, we assure you that at least she'll be 10% better than where you started off. So what we decided that we'll first explore the neurovascular anatomy with a plastic surgeon's help with microscopes and everything. if there is an entrapment, we were prepared for free vein grafts with an anastomosis. As long as one patency was there of the main brachial trunk, we had prepared that, and we were sure that within 2 years, enough collaterals will be there. But at the same time, if we need to excise that part as a part of the entire mass, then we were prepared for a nerve anastomosis as well. Luckily, we didn't really need it. And we pre-marked the area which we had already planned on CT scan as to how much we are going to remove. Then we had decided we will interpose some inert material so that there is no biological bridging that can happen across the thing. But the most important thing, I think, what has worked is a combination of all these things. The interposition, a long-acting block was used with the help of the anesthetist from the supraclavicular region, where they give clonidine and they put in a catheter. Almost up to 3 to 4 days, they can maintain the complete pain relief over there. So under the block, we had planned that from day 2, 48 hours later, we will immediately start mobilization. So those are the intraoperative images. Those are very, very large incision bringing on, starting from the lateral border, going up to the middle and going on to the considerable part of the forearm. That you can see, this is the brachial artery, ekdam close to the mass. This was very painfully dissected. It took almost 1.5 hours to isolate this whole thing and bring it out. Luckily, it was patent nicely and it did not need any resection anywhere except for one small minor branch here. And the median nerve was also plastered along with it. So this, with our plastic surgeons' helps, we managed. And then we removed, that's the, after retracting everything, that was only the bony bridge that is left behind there. We marked it under the C-arm. I will show you how much we marked on table. And then after the removal, we again ensured that both were patent and left intact. So that is the marking that we did on table. We just decided to go just enough to free the radius and the neck of the radius and allow the radius to slide over the ulna there. And on the humeral end, we intentionally went a little below into the mass. We could have gone all the way up here where you could actually see the cortex of the humerus, but we intentionally left it there because we didn't want to thin this out too much. As when you excise with the help of osteotomes and hammers and do a piecemeal excision, sometimes you end up going into the medullary canal too much and you're sometimes just left with a little bony ledge. And despite that, you can see that out here, the humerus was pretty thinned up. So after removing this entire thing, that's the kind of beautiful opening that we got. And the radius and the ulna were totally free to glide onto each other. That's the full extent, near full extension on table. I won't really say it's a full extension, but we were able to get a less than 90, around 80 degrees flexion on table there. And this went on to work very well. We interposed some Surgicel and the fibrin glue, which we are using in brachial plexus repair and for physeal bar excisions and using as an interposition arthroplasty. So we formed a thick layer of that and we put that in the interposition so that that doesn't react with the tissue later. And we also, of course, started on indomethacin. Plus, we gave her preemptively 2 cycles of radiation from Tata Memorial. So this is how she panned out in the end. We protected her, by the same time we kept giving her mobilization. And that's the kind of result we got at the end of 1 year follow-up. She got a functional arc now. I won't say it is the best result and that we could give her a full range. That was perhaps impossible. We had never even imagined that we would manage to do that. But what we managed to successfully break is that entire bridge that was here, retain good amount of the humeral cortex and give her usable extremity. So just some discussion on myositis, that occurrence of traumatic heterotrophic ossification is actually difficult to predict in a lot of elbow cases, but the elbow is a very notorious joint for the same in children. So one should always look out for risk factors like history of massage or manipulation or presence of head injury if you see heterotrophic ossification. Radiotherapy and oral NSAIDs are the primary treatment for heterotrophic ossification. In this case, it was already very advanced. So we use them only on table or immediate post-op so that it wouldn't reform again. And if it is a very well-defined linealated mass, do not hesitate to do it, but with careful preoperative planning and keeping standby things. It's best done after maturation of the mass. And if you do a well executed surgery, you can have quite successful outcomes. Not perfect, but yes, to a great extent, at least functional. And those are the references for anybody who would want to read up, and quick round of questions we can have.
Madam, wonderful case. It is not actually myositis ossificus is not a very rare disease. It's a very common occurrence.
Common problem.
If you have managed it and protecting the neurovascular bundle, excision of mass is not a very heroic surgery, but the heroic surgery is protecting the neurovascular bundle. And that is, I must compliment.
Thank you, sir.
Excellent preoperative planning, and step by step, whatever you wanted to have, or pre-planned very well. So I think that has helped you a lot, I suppose. Yeah.
Yes, yes.
Yeah, very, very well executed case, Rujuta. Great thing. Only one suggestion I want to make. If you use an elbow hinge by orthofix, you can increase the range of movement later on post-operatively.
Yeah, that's I think, very good tip you've given us. But unfortunately, what happened is that this was done in 2019, early 2019, sort of. And the first follow-up which she gave us at 1 year was sometime in Jan 2020. And ever since that time, after lockdown, patient has just disappeared and never turned back. But in future cases, I think it's a good tip. Here, the challenge and the worry basically was, since the entire brachialis was involved, I was also worried about some flexion weakness later. But I think that's something which one has to carefully counsel them from the beginning. And biceps being a very good powerful muscle. The good thing was that biceps wasn't really involved. That has, I think, saved the day for us.
Madam, can you clarify on how much indomethacin should be given and how long? One question. And you also said about radiation also. So how many doses you have to give and at what interval, and after that radiation, after interval, when to do a surgery? And after the surgery also, whether the radiation is needed or not.
Yes, so let's go the reverse way from the second question. The radiation is better only for, and indicated only for, preventing myositis. So here it was done immediately post-op, 2 cycles. I forget the exact dose at this stage, but it was given 15 days apart. And since it was in Tata Memorial right next to us, and we had retained the patient in-house for that long, but ideally they recommend at least 4 cycles, 3 months apart, so that we are entire phase of primary and secondary healing should be completed, and you should not get any new callus formation. So that's when it is indicated. Radiation cannot be used on an established myositis or on a progressing myositis. It is effective only before. Indomethacin, what we standardly give is 25 milligrams twice a day, which is like an adult dose. But we make sure that it is given to children 10 years and above only. We make sure that PAN 40 is given along with it. And you must tell the parents that it has to be given with food or cold milk. And the child must be able to sit upright at least half an hour or 1 hour after taking the tablet. In children younger than this, one may give about half the dose. It's a capsule usually, so difficult to give as something to be swallowed. It's unfortunately simply not available as a syrup. So what I tell the parents is, open out the capsule contents, take 1 teaspoon of honey and mix it in that and let the child lick it. That also kind of works. And the first question.
Okay, sorry.
Yeah. The first question regarding NSAIDs was that whenever you're dealing with an acute trauma, definitely you must give it, especially elbow trauma, you must give it to all difficult trauma cases for at least 2 weeks post the trauma, and tell them never to go to a physiotherapist, never to go for any malish massage. The children, best thing for them is that just give them play therapy and give them a ball to dribble or give them badminton or a TT racket. They'll regain range. You never need a physio for a child.
Rujuta, I was just wondering whether radiation in this case was absolutely necessary. Because could we have done without radiation, because it's just an 11-year-old child, and just with indomethacin after complete excision, just with indomethacin, could the child could have been managed? I mean, was radiation absolutely necessary?
So it's not an absolute indication, but maybe because of the large extent of the mass, and we were really apprehensive as to what kind of a result we would get. We thought that sometimes what looks great on table in the first 3 months steadily starts going down. So basically it was maybe an overcautious thing on our part, and that's only 2 cycles. We didn't get a chance to have it post-op, but not more than that.
Because we get such cases, and we never give radiation therapy to children, especially, No,
but this was a very huge mass. That's the only reason. I haven't given it to others, but anyway, the only value is for prevention. So maybe sometimes if it's a very difficult surgery or very select cases, one can look at that. Yeah, Neha was asking something.
2 quick questions. Was there a problem in wound healing in this patient? And the second one, that sometimes supracondylar humerus fractures, they come from a quack with history of massage and LAPE application. So how do we counsel them? And do you give preventive endomethacin and radiation to those children, or what is your protocol?
So protocol, we'll start again from the second question. Protocol is to give only endomethacin when there is already a history of LAPE and manipulation. Just let everything subside. Do your alkaline phosphatase, palpate whether it is a warm mass or is it a quiescent myositis. Let everything subside. If something is already a late supracondylar, do not be in a hurry to try and fix it. Beyond 1 week of untreated supracondylar, I won't use the word neglected. Beyond 1 week of untreated supracondylar, usually it is pointless to try close reduction, because then you will end up giving so many manipulations in spite of GA. So you will end up giving them myositis. So it's better to then proceed with an open reduction if you have to, or let it malunite. You can always correct the deformity with a cubitus extension osteotomy. Many form of corrective osteotomies are there, not necessarily French. Now you have a very nice double equal limb osteotomy by Scott Cozen, and you can use fixator guided correction. There are so many options. You can always correct it better when everything is cold. So only protocol that time is 2 weeks of endomethacin, and let everything gently fall into place and get gently mobilized. And your first question, wound healing, luck by chance, or maybe it was God's grace that we had involved a plastic surgeon. The flaps were really very glabrous, very gentle, and very slowly sinuous. So did not have any wound healing problem.
I think Dr. Kiran Saoji from Nagpur wants to ask something.
Sir, you are muted.
What are the side effects of radiation? As Madam said, you should not give.
Yes, so radiation basically is many things that can go wrong with it, right from necrosis to even they do say that think that it's of dubious value and it may give rise to other growths in future. So radiation is generally not preferred except for preventing, and that's why it has a very limited role in some cases.
Especially in females also.
Yeah, but the amount is really not that much. And now if it's a limb, you can have localized brachytherapy.
Yeah.
So it's not really, and low dose, just 2 cycles should be okay. If you have to use it in selective cases. I'm not recommending it as a protocol for everybody.
Yeah.
The routine protocol is endomethacin, wait, and gently mobilize.
Gadegone, there are so many children or so many people come with here in this area. They have got quacks and many LAPE applications. So what is your take on that? How do you handle these patients?
I don't do anything. I don't do anything to them. Just as he said, let it malunite, regain some function after 1 or 2 years or 3 years. We can do a surgery. There is no problem about it. And I never interfere in massage patient and neglected, we can say maltreated fracture after 10 to 15 days, because they are radiologically they are showing some changes of union.
Okay.
Let's move ahead, Neha.
Yeah. So our next speaker is Dr. Poonam Mukhi. She did her UG from Grant Medical College and Sir JJ School of Group of Hospitals, PG from MGM Institute of Health Sciences, Navi Mumbai. She was the first female orthopedic resident in her institute. So her special interests are arthroplasty, LS spine surgeries, and trauma. After passing out in 2013, she immediately joined her father, who's a renowned Dr. S.R. Mukhi sir. So she was trained under him for arthroplasty, and she's currently practicing with him at Raj Hospital. So over to you, Poonam. Poonam, can you unmute yourself?
Am I audible now?
Yeah, you're audible. But yeah, now start sharing your screen. Yes. You're able to see your screen now.
You are able to see?
Yeah, you're audible and I'm able to see your screen. Just you need to
slide share. I'm just
already shared. You just need to play.
Yeah, go full screen and play.
Full screen. Okay, thank you so much. Thank you so much, Maharashtra Orthopaedic Association and Voice. This is my first presentation, and special gratitude to Dr. Rujuta Mehta ma'am. If it was not for her, I don't think I would have been allowed to take up orthopedics as a mainstream branch for practice. She knows why. So, ma'am, special thanks to you for letting me into your circle and giving me this opportunity.
Sure, sure.
So my case is a 76-year-old
do play,
male.
I think. Do play. Click on the play button.
Ma'am, I did.
Not moving ahead.
Not?
Poonam, your slideshow is not running. It's just we are
share again. Stop sharing and share again.
Stop sharing. Okay.
Now share again.
Share again.
Double click to enter full screen mode, it says. Yes. Go on.
Okay. Yeah, now is it okay? Yeah. So
yes, perfect. Go ahead.
My case is a 76-year-old male. He came to us wheelchair bound since 3 months. Severe bilateral knee pains, and particularly the right-sided shin pain was extremely painful. His hip and spine examinations were normal. On examination, he had joint line tenderness on both the knees, and especially on the proximal tibia on the right side. Krebs and severe varus in both knees was seen. He was hypertensive, diabetic, and with the ejection fraction of 45 to 50%. So these were his x-rays. As we can see, really osteoarthritic knees, tricompartmental osteoarthritis. And there is a fracture at the proximal tibia. The patient did not give any history of any injury or trauma. He says it was all of a sudden that one fine day he started feeling these shin pains. So going by his age and reduced activity levels and looking at the quality of the bone, this was most likely to be a stress fracture. So when we saw this case, our main goals were to correct the mechanical alignment of the lower limb, do the TKR, and get the osteosynthesis at the stress fracture site. So we reviewed the literature, and the first mention of stress fractures in proximal tibia along with ONE is given by Wielden in 1961. And there is a very good series of articles which are posted on the management of such cases. But the biggest series is by Dr. Arun Mulaji. And he has given the steps to manage such cases. This article is from 2010. It's a beautiful article. And when we reviewed all these literature, they recommend that you need to first find out the underlying cause. And when you're managing these cases surgically, the tibiofemoral alignment at the knee has to be done first. So the total knee arthroplasty to be done first, then correct the extra articular deformity, whether it's a varus or a valgus, that needs to be corrected. And always stemmed implants. So over a series that is mentioned in the literature, they finally come down to the fact that narrow stems of 8 to 9 millimeters should be put to avoid distal cortex perforation while doing such cases, and bone grafting, if needed, to be done at the stress fracture site. So in the pre-op planning, when we saw the deformity, it was around 18 to 20 degrees, a moderate category. So we decided to go ahead to do it as a one-stage procedure. And the biggest challenge was that I am trained in AGC knees, and AGC knees don't come with stems. They are the primary knees only, the short tibial stems and the femur patella components. So with due respect and permission from my mentor, Dr. S.R. Mukhi, I've picked up some slides from his presentation at the Katra Curation. And what we did was we have designed these slotted fix the short stem of the tibia of the AGC component. So both the front and the side views that you see, and these stems can be plain stems or locking stems if needed. The lengths of the stems vary, but the thickness is either 8 millimeters or 9 millimeters, not more than that. And when we proceeded with the case, as suggested by literature, first we did the routine steps of the normal TK, normal cuts taken. Then through the tibial jig, the slot for the tibial stem that is made for the component stem, we got the canal finder and opened up the distal canal, bypassing the stress fracture site. The stress fracture was opened and the fibrosis was removed before passing down the canal finder. The deformity was corrected. Then as a trial, we put the nail of the length that the distal canal that passes the fracture site, the length of the nail has to be twice the diameter of the cortex. Then we put in the trials, assess the flexion and extension gap balancing, and check for patella tracking. Cementing was done and the tibial implant was fixed with the stem first before it was fixed to the bone. And when it was put in, we had taken steps to see that the varus deformity was in the correct alignment before cementation was complete. And for bone grafting, we used the bones that we had after the cuts were made for the total knee. So all the chamfer cuts, the remnant bone that is usually in the kidney tray, was the bone that was morcellized, the cancellous bone that was morcellized and put at the stress fracture site. So this is just a short video. This is from another case, but just a demo on how we fix this nail to the tibial component of the AGC knee. So usually the cement are the metaphysis and the surface bone cut surface. No cement is put at the distal portion of the nail, and it just fits beautifully inside the T of the tibial component. So this was the immediate post-op X-ray. And then this is the 1 month follow-up X-ray where we see that a good callus formation is happening at the right side. And at this stage, the patient demanded that his opposite knee also be done because he was very happy with the first surgery. And he proceeded to do the second knee at 1 month. So on the right, we have operated on the left knee. Same procedure, exactly the same procedure. This is the X-ray at 4 months. And this is the clinical picture of the patient at 4 months. He's so happy to walk. He's just so happy to walk. 2 months, he is like, can I now leave my stick? But since he was going back to his village, he would not be around for follow-up anymore. We asked him to keep on the stick for another month or so. But this morning, he has sent me his fresh X-rays and at 5 months, and he has just stopped using the stick. He's not using it anymore. So, and we see that there's a very good union that is happening at the stress fracture site. There are some other cases I want to share using this technique because this has been a very wonderful technique in our hands. So this was a 64-year-old male with a V-nail done 20 years ago, and multiple attempts at removal were made. He had knee pains and he could not undergo the arthroplasty because the nail was not getting out. So we had to do serial drilling of the anterior cortex, slit it open and get the nail out. Then we corrected this deformity, the same armamentarium, same setting, just a longer nail. And this was done. And I have the clinical pictures of his 1-year follow-up. This is another case, a 72-year-old female with bilateral stress fractures, same technique used. And this for the stress fractures of the tibia. These are a 2-year follow-up x-rays. And now we are using this technique for severe various deformities where usually it's recommended to do the TC3 implants, but this is giving us an opportunity to use a primary AGC along with the stem. So we have been using this procedure for severe tricompartmental arthritis as well. So thank you very much. And I would like to hear your questions, comments, and suggestions.
Very, very well done, Poonam.
Thank you so much, madam.
I've not really been in the world of arthroplasty at all, but just a few questions from me, very, very small questions actually. What were those 2 screws below the tibial component in the other knee of the, and what is the principle behind it, and how does it help?
Right. So what had happened was when we did this other knee, while cementing, we realized that the bone was so weak that the cortex was splitting. The proximal tibia was getting into a slit. So those screws were put in prophylactically. The horizontal screws you see at the time of cementing were put in prophylactically to prevent that. And the diagonal screw is the one that is, nullifying the defect, the varus defect that you see in the pre-op X-ray.
So is this a routine recommendation that you would make now for stress fractures?
Ma'am, routine. Yes, this
would
is
you make this as a routine
recommendation?
recommendation? And any alternatives to that? Should the orthopedic surgeons keep allograft handy and try to augment or give support from below?
Literature says that if done well, even without bone grafting, most fractures, stress fractures with osteoarthritis knees done with stemmed implants show union by 6 months.
Okay.
So they don't even recommend bone grafting, but since the bone is aware, the cuts that is taken, we routinely do bone grafting to be better safe than sorry. Because especially with such fractures which are closer to the knee, you just need to extend the incision by 4 or 5 centimeters more and open it up, and you have a direct access to the fracture. The cancellous bone is already available as a graft in the kidney tray after the cuts. So we just morselize it and put it there. So, we have covered all possible options that are needed.
That's great out of the box thinking.
Yeah, Poonam, good presentation. Do you have any scanograms post-op? Have you taken the scanograms post-op for the alignment?
No, ma'am. No, ma'am. We do the standing x-rays, but we have not taken any scanograms post-op. But if the patient turns up for follow-up, I will take a scanogram and post it on the group.
Great.
Yes, Poonam, it was not only a challenging case presentation, but also innovative. So I would just like to ask one question. How do you prevent extravasation of cement from the stress fracture site?
So in our practice, we are not using liquid cement or the cement guns. We are using Palikos cement. And usually, like I showed in the video, it's quite a doughy consistency. And the cement is put on the cut surface of the bones and the implant at the metaphyseal area. If you carefully look at this video on the right, I have shown it that the cement is not in the distal part. So this cement usually doesn't leak out at the fracture site because the distal end of the nail is totally uncemented. So this does not leak out. And since it's so doughy, it's very, very rare that it will reach the fracture site in the first place.
Right. Sure. Thank you. Are there any questions from Poonam?
So is this your own SIRS innovation, or is this implant available as a routine? Like, can you order?
No, ma'am, this was SIRS innovation and we all got trained with it. This was SIRS innovation.
Superb. Very good.
This was SIRS innovation because he was like very, very happy with the results AGC was giving him. And when such cases came, the only thing that was required was a stem, which the AGC was not providing. And so he designed the tibial nails that would fit that slot. So we have nails with the locking mechanism also for very, very distal fractures when we feel that the rotation is not right. We have those handy, but we have not, it's not been required by us to use them so far to lock the nail distally. So far we have used the non-locking tibial nails.
Okay.
Yeah.
So thank you. Thank you very much, Poonam. Can you stop sharing your screen? Yeah. So we move on to our next speaker. This speaker is from Panvel, who has just finished her SR-ship from MGM Medical College, and she is currently working in Reliance Hospital and Mhatre Accident Hospital, Panvel. Please welcome Miss Juliee Mhatre. Yeah, Juliee.
Am I audible?
Yes, you're audible and your screen is also visible. You just need to start the screen slideshow.
Firstly, thank you for giving me an opportunity to present on this platform, and amazing presentations by all the presenters until now. So to begin with my case, I would like to start with how the patient presented. So this is how the patient presented to the OPD. He was a 23-year-old male patient and he was waiter by profession. He was left-handed. However, what deformity you see over here was on his right hand. So his chief complaint when he came to us was only a claw-like deformity, as you can see in the image. On further probing, we found out and he gave us a significant past history of trauma to the same forearm 4 years back. And we were suspecting that it could likely be a fracture of distal and radius, followed by which he went to a bone setter and some wooden splints were put, and later on he developed excruciating pain, for which they removed the wooden splints, and then they found some blisters on the volar aspect of the forearm. And after that, this patient did not receive any treatment and he ended up in our OPD after 4 years without taking any treatment. So to summarize the history, it was a claw-like deformity, which was his main complaint, a past history of trauma with bone setter doing something, and skin blisters followed by it, and after which there was no treatment, and then the patient presenting to us with this deformity in the OPD. So then we went ahead and we examined the patient. On examining, there was skin changes, scars, as you can see over here on the volar aspect of the forearm. Also, we saw severe wasting of the thenar, hypothenar muscles, and the forearm muscles were also wasted severely. And then looking at the deformities, he had fixed flexion deformity at the distal interphalangeal joint, proximal interphalangeal joint, and the wrist. And his metacarpals were in extension. And he had kept his forearm in a pronated position. However, his elbow range of motion was quite okay, and the extension of the wrist was also slightly possible. So this is a video of how he presented. So this is a classical Volkmann signs which we can see. On extension of the wrist, he is able to flex the proximal and distal interphalangeal, and vice versa. So to summarize the history and the examination, on examination, we found severe wasting, deformities at all the joint, sensations which were decreased on the thenar, hypothenar, and forearm aspect, and a positive Volkmann's sign. So we just got his x-rays done to rule out any current fracture, and these were his current x-rays, which were not suggestive of any fractures. So finally, after the history, examination, and x-ray part, we came to a diagnosis of Volkmann's ischemic contracture. So now to treat this patient, firstly, we wanted to correct his deformities and give him a better functional outcome. Those were the goals which we were thinking of when treating this patient. So in stage 1, when we took the patient up, we took a volar incision on the forearm and exposed all the flexor tendons. And we went on to do a fractional lengthening of all the forearm flexors. And at the same time, we even performed tendon transfers. So because his extensors were functional, so we could go in for the tendon transfer part. And then we closed this incision with a drain in situ. And immediately post-op, we gave him a functional dorsal slab, and we started passive extension of the metacarpophalangeal distal and proximal interphalangeal joints with passive rubber traction units. Then we followed him up after a month after suture removal and all. We found that there was still slight flexion deformity present at the wrist. So we thought of reducing the forearm length so as to decrease the flexion contraction. So we went in to do a proximal row carpectomy, and for that we took a dorsal incision. This was the stage 2 which we did. We took a dorsal incision. The proximal row carpals were identified, that is the scaphoid, lunate, and triquetrum, and we performed a proximal row carpectomy. So these were his x-rays post-op, the stage 2 procedure, and he tolerated the procedure very well. And after that, we followed him up after a month's time, and his deformities seemed to be well corrected. So then we thought of giving him a better functional outcome. For that, we wanted to do an opponent's plasty so that he can use his thumb to oppose, and that would give him a better functional outcome. So to do this opponent's plasty, we want in stage 3 procedure, we selected the extensor indicis proprius to be transferred to the abductor pollicis brevis. For this, firstly, we took an incision over the metacarpophalangeal joint of the index. The extensor indicis proprius tendon was identified over there. On the same dorsal aspect, at the musculotendinous junction, we identified the same muscle. We harvested it, and then from the ulnar side, we rerouted it and took it all the way up to the abductor pollicis brevis, and it was woven into the normal insertion of the abductor pollicis, so that it could give him a opponents of the thumb. And so to summarize the surgical procedure, in stage 1, we thought of correcting his deformities. So we did a fractional lengthening of all the flexor tendons and tendon transfer. In stage 2, to further correct the deformity, a proximal row carpectomy was done. And finally, to give him a better functional outcome, we went in to do an opponent's plasty. So these are the post-op clinical pictures of the same patient, where the wounds are all well healed. And this is a short video wherein he is able to do extension at the movements are improved, and the opposition of the thumb, as you can see, just a moment. Yeah, he was also able to do opponents of the thumb. And overall, the patient was very happy with the functional outcome which we gave him, and the deformities were also corrected. So that was about my case. Thank you.
Thank you, Juliee. That was really a challenging case. And I would like to ask our seniors, Sujata ma'am, your take on the case.
I think good result, Juliee. I just wanted to ask you a few questions. What was the sensory loss? Did you have to do a neurolysis as well?
No, his sensations were comparatively, they were decreased as compared to the opposite side, but they were quite intact. That is why we decided not to go in for a neurolysis.
Okay. And the second thing, do you think a wrist arthrodesis may have been more beneficial, or you feel this is better?
Since a proximal row carpectomy would give him a mobile wrist, so it was better to do a proximal row carpectomy as compared to an arthrodesis.
Okay, because he seems to be in little flexion, do you think? Or
ma'am, towards the end you are talking?
Yeah, the final thing, do you think there's slight flexion at the wrist?
Yes, ma'am, we are still continuing with physiotherapy, but it was much better as compared to what he had
No,
presented.
it's an excellent, really excellent result. Very nice. Well done.
Dr. Sautry sir wants to ask something.
Really excellent result. Very functional hand. Very good result.
Thank you, sir.
Just want to ask you one more thing. Did he have any flexion deformity at the elbow?
No, ma'am. His elbow range of motions were quite well maintained, so that we did not have to look after him.
Okay, so you did not want to do a flexoplasty like from the origin?
No, ma'am. We only had to do fractional lengthening for the wrist and the DIP and the PIP joints. For the elbow, we did not have to do it.
Oh, superb. Really good.
Thank you, Juliee.
Just maybe quick tip from me, Juliee. Would you have considered doing a max page flexor pronator slide as well and radio ulnar shortening? Because that would have given you a little more working length, after which you could have gone ahead with the fractional, and that would have helped you bring the wrist out a bit more into extension and retain some more of the function. Agreed that VIC is difficult, and agreed that already counseling them for multiple stages is not easy to convince all patients. But would you have added a max page?
Ma'am, this was the best we could do, and it was difficult to counsel him for the second proximal row carpectomy also. So,
because in children, that's what we tend to do first, so that we begin from proximal to distal. We come down slowly.
Yes.
So just a tip, but I mean, Vidisha is also here. Maybe she can add something to this. Vidisha, are you with us?
I agree. Sometimes it is better to do max page and then second stage lengthening if there is any residual deformity. Sometimes fractional lengthening, before that, you can get it done with a differential distraction with the hinge fixator or Ilizaro ring fixator. Rujuta must be doing this differential distraction.
Yeah, so I would have used Jess, but in children. So in adults, I think you're the better person to opine. But yeah, again, a great tip to use an external fixator and try and give it more length. So, let's proceed, Neha. If there are no more comments.
Yes. Okay. So thank you, Juliee, for the wonderful presentation. So we'll proceed with our next and last presentation by Dr. Chaitrali Gundawar. She completed her undergraduation from Bharati Vidyapit and post-graduation from Ruby Hall, Pune. Currently, she is doing fellowship in pediatric orthopedics in Sanjiti Institute for Orthopedic and Rehabilitation in Pune. So over to you, Chaitrali.
Thank you, ma'am, for such a wonderful introduction.
It is an honor for me to be here today and presenting my slide. So to begin.
There's a bit of an echo, Chaitrali. Are you from two devices or?
No, ma'am, single. Am I audible now?
You're audible, but there's an echo, strong echo along with it. So there's an extraneous sound which something needs to be done about.
Ma'am, I think from my side, there's nothing wrong. Do you want me to restart? You can just stop sharing once and then.
मॅडम थोडंसं दुरून बोलायला लावा त्याला होऊन जाते थोडं दुरून बोलायला लावा
ठीक आहे आता
हो थोडं दुरून बोल बेटा
or use headphones, one of the two.
Ma'am, headphones my headphones are not working but
थोडं दुरून बोल म्हणजे होऊन जातं दुरून बोल
हो ठीक आहे. Okay, good evening everyone. I would like to start with my history. So we had a 22-year-old female who was a dancer by profession. She had a history of on and off pain over her right shin of tibia, which was more at night since the past 4 years. She had shown multiple doctors and was initially told that the pain was due to an extensive dance. She was treated symptomatically and analgesics were given for around 5 months, after which pain was relieved but reappeared when the medications were stopped. She presented to us after 4 years with the same complaints of pain. So going back in the past history, in October 2019, X-rays were repeated, which was reported to be as normal. MRI was suggestive of a focal periosteal reaction along the posterior medial cortex of the distal third of tibia, and intramedullary marrow edema was seen, but no fracture line was visible. Soft tissue edema was present in the anterior and the posterior compartments. After 3 months, she was referred to another doctor. A USG was done this time, which was suggestive of a hypoechoic lesion in the lower third of tibia. Mild peripheral vascularity and inflammatory changes were observed on the Doppler, which was again suggestive of a subperiosteal abscess. MRI was unchanged and the marrow edema was prominent and adjacent soft tissue swelling was seen. So patient went on from here to a higher center where another MRI was repeated. The findings now were suggestive of an infective pathology like osteomyelitis with again a subperiosteal collection. Here she was counseled that the pathology looked more like a tumor, but in this case they told her that it would most likely be a Ewing sarcoma. Hence the patient was put on a 7-day course of antibiotic to see if the pain was getting relief, but sadly she was still complaining of the same pain. In 2020, she was operated for debridement and biopsy, following which the biopsy clearly mentions that it was consistent with osteoid osteoma. The bony trabeculae was appreciated, hence the diagnosis. In 2022, she came to us complaining of pain. There was no, the pain was still there, more at night. So this was again a contrasting feature, which she told everyone for the past 4 years, but probably no one picked it up. So the pain was consistent. And as a protocol, we got her X-ray done. So in this X-ray, we can clearly appreciate the reactive sclerosis around the cortical thickening, which is seen. We did a CT scan in this case, and it was diagnosed to be an osteoid osteoma. So these are some of the films here. We can clearly see the lytic lesion. Nidus can be appreciated. Reactive sclerosis in the bone marrow can be seen with the cortical thickening. And even in this film, we can see the nidus. So here on, patient was RFA was done for the patient, that is radio frequency ablation under OA was done. She was pain-free post-op. Immediately she told us that the pain which used to be there was not that kind of pain. So that's when we realized that she was pain-free. And at a recent follow-up of around 6 months, she was very happy with her results. In short, I would just like to conclude by saying osteostoma, it is a painful benign condition accounting for almost 3% of all the bone neoplasms and 10 to 12% of the benign lesion. It most often involves a diaphysis and metaphysis, more commonly seen in children not after the age of 25, more commonly seen in femur and tibia.
To highlight a few points, as plain radiographs usually show no abnormalities in the early stages, they have little or no diagnostic value. However, they are still required for elimination of other conditions and should be the first in line of diagnostic investigation. MRI, on the other hand, can be misleading, as we saw in this case, as the detection of bone marrow edema during the early stages can lead to a misdiagnosis of the conditions. Hence, CT scan remains the investigation of choice. It determines the nidus and also helps in the pre-op planning of the intervention. Radiofrequency ablation is a minimally invasive technique to burn the focus of pain. Percutaneous ablation is reported to be a safe and a cost-effective procedure at the same time. It has an advantage of being on a shorter duration. It lowers the risk of complication as compared to the traditional curettage and resection. It has proven to be highly effective in the treatment of osteoarthritis. Initially, RFAs were performed in a diagnostic CT radiology suites as it requires CT for the guidance of the probe insertion. But with the advent of O-arms, performing RFA in operative setting has been possible and has several advantages. I would just like to mention a few. So the sterile environment reduces the risk of infection. Repeated CT scans can be performed. Real-time surgical navigation is possible while doing the procedure. Use of this cone beam CT reduces the radiation dose exposure to the patient, which is very important in children. We can easily switch between a 2D and 3D image as and when required. And standard anesthesia techniques can be followed during the procedure is being done. So here I would like to show the procedure which we follow usually for these osteoid-osteoma patients. This is the patient positioning. We take the position in which we use the shortest route of access from the skin, which should be decided, and the O-arm is placed in this fashion. So with the help of a percutaneous guide wire, we under the influence of fluoroscopy, we reach the cortex of the bone, and with a drill hole nidus, we reach the nidus. The nidus and then can be located and targeted in both the coronal and axial planes on taking multiple shoots. So in usually not more than 2 shoots are required to reach the particular target. It is very important to check the deployment of this RFA probe to see if every probe deployment is working. This is the RFA machine. The temperature can be set, the timing can be manipulated here, and we have to check if each prong has the same amount of temperature so that equal amount of temperature is focused on the lesion. So usually we ablate it at a 90 degrees Celsius for around 5 to 6 minutes, and the lesion is then necrosis portion of the lesion can be seen here. And we also have to be careful that we sprinkle some water around while the probe has been burning, so that the skin around the skin does not get burnt. So in short, I would just like to end by saying that CT scan is the gold standard investigation of choice in cases of osteoid osteoma if it is suspected clinically. And O-arm assisted RFA can be definitely considered over a CT guided RFA if it is available in your institute. Thank you.
Nice presentation, Chaitrali.
Thank you.
So 2 things from my side.
Yes.
I would just like to ask you, RFA costs are pretty prohibitive in a lot of places. So would you recommend it routinely even for superficial lesions like the tibia, which is very, very accessible? Or would you reserve it for areas like the pelvis, spine, neck femur, where you want to have the advantage of a minimally invasive surgery?
So ma'am, I think RFA is quite precise at finding the location, and we can be sure that the whole lesion is burnt out. If we go for the traditional curettage, it is sometimes like in this, they also try to go for the curettage and they probably miss the lesion, and probably it recurred or they missed it. So that is very difficult to judge. I think this is like a for sure we can know that the lesion is born.
So I agree. I mean, I'm not debating the usefulness of the RFA. What I'm saying is, in our country, would you reserve it for deeper, difficult access areas or areas where,
Yes, ma'am. For spine cases, it's very difficult to look.
Yeah, very, very good for those difficult regions. And the other thing is, what is your opinion on CT guided drilling, which is what some surgeons are recommending nowadays, over a conventional open curettage?
Ma'am, CT guided drilling
like a forage, you know what they do in the neck femur with a triple reamer. So they just take a thicker, so they core out the entire osteoma, but they do it CT guided. That is what some surgeons are recommending nowadays. So what's your opinion on that?
Yes, ma'am. It can be tried. I haven't personally seen cases in that, but the literature also has said that you can try and it has shown good results. But I would also like to mention that recently I read this paper where they're using magnetic resonance guided focused ultrasound. So it is basically a non-invasive technique, and the mechanical energy is converted into heat, which ablates the focus of the lesion. So there are many new techniques which are also coming up, so which can definitely.
Yeah, one is always on a constant search. Good.
Yes.
Nice.
Chaitrali, I wanted to ask you, did you review the previous MRIs which were done? Because the axial cut of the MRI shows the nidus very well. So one reason it was missed, probably they took the cuts too far apart. I don't understand how they missed the osteotomy and the MRI. You can diagnose it on an MRI.
Probably, ma'am, because
traditionally the CT is this thing of choice, but
yes, ma'am. Probably because of the marrow edema, it was
No, but you can see the nidus very well. Like you have taken the axial cuts with the CT, the same axial cuts with the MRI, you can see the nidus very well. So I'm surprised it was not diagnosed. And the second thing, as you said, after the first surgery, it was diagnosed as an osteoma, but probably the lesion wasn't completely removed.
Right. So they did try to remove the lesion, and they told the patient that you would be pain-free after that because we thoroughly curettage. So we are in a dilemma as to if it was a recurrence or the lesion was not removed completely.
Yeah. So do you know what an osteoma looks like? What is the pathological portion of the osteoma? Is it the thick bone?
Ma'am, it is the focus of nidus.
So what does that nidus consist of?
It consists of prostaglandins, mostly prostaglandin E2, which are released slowly, because of which there is pain.
Actually, it looks like granulation tissue. You know, it looks just like a granuloma. It's a soft vascular tumor. It is like a granuloma. So the bone surrounding it is not the issue. That is the reactive sclerosis of the body.
Right.
It is that vascular granuloma in the center of the nidus which is causing the pain.
Right. Yes.
One more thing I wanted to ask you, are you all doing the radio frequency yourselves or are the radiologists doing it?
Ma'am, we do it ourselves. I think my consultant, Dr. Sandeep, he has been doing it for the past 15 years with excellent results.
Good.
It does have a learning curve, but if you get to that, then your results are fantastic.
Very nice.
Only difficulty is it's a very costly procedure. I think it costs more than 1 lakh rupees I saw. So for accessible lesion, it is better to have an open and drilling. And for inaccessible lesion, it is a good thing that you do a radio frequency ablation. So very nice, Mehta madam, तुमचे सर्व स्टुडंट आणि कलिग्स दे आर व्हेरी एक्सलंट अँड ब्रिलियंट प्रेझेंट. I am very thankful to you all. And Neha, over to you, and you can conclude.
One comment. Hello.
Yes.
In our institute, we are doing regularly RFA. That interventional radiology they do, but only one precaution. One patient had a very bad burn injury. That should be kept in mind.
Yes, sir.
And
Hence I mentioned that we sprinkle water when the procedure has been done so that the skin does not heat up and burn.
yeah. We have presented that case also. Published.
Okay.
Thank you, sir, for a very valuable comment. Every technology should be, both sides of that should be kept in mind. Thank you, Sauji, sir.
So it seems like there are no questions for anyone. So it seems like end of the discussion. So I'm really overwhelmed how our girls have presented really so well, and they had so many challenges and they still did very, very good. Thanks to our speakers, Poonam, Chaitrali, Mithali, and Juliee, and also our senior young surgeons, Dr. Rujuta ma'am and Dr. Binoti ma'am. First of all, I would like to again thank MOA and our president, Dr. Gadegone, for his idea to start Women's Wing in MOA. And thank you for your encouragement, sir. I also like to thank Dr. Manoj Pahukar for his coordination with all of us. I'm really grateful to Rujuta ma'am, who's a pillar to us, and for forming this group of voice or ANMOL series. And I would like to thank our panelist, Dr. Rujuta Kulkarni ma'am. In spite of her busiest schedule, she has given us some time. Also, we'd like to thank Dr. Sujata Aiyer ma'am for actively participating and giving her knowledge, the words of wisdom to us. And last not but the least, but I would like to thank OrthoTV, Dr. Ashok Shyam sir. Thank you for giving us this platform. Always, I would like to also thank IOTV. We are really delighted that we are going on a large platform, and our speakers really have done that good job and shown that this platform we are really doing really good. And I'm really seeing Dr. Arora ma'am, who has joined, actively participated, Dr. Kiran Sauji sir, Dr. Vidisha Kulkarni ma'am. Thank you for joining us, and thank you very much. Rujuta ma'am, you want to say something?
Neha, next third webinar in the month of September. Please prepare.
Yes, certainly.
In the month of September, and last in my tenure will be in the December. Okay. So there are 4 webinars are given to you. 2 are already completed. We will complete more to September and in the last December. Okay.
Sure, sir. Sure, sir. Thank you very, very much for this wonderful opportunity. I think what I would like to say in the end is all of you all have great potential. I see a lot of different specialities coming up. For example, Juliee did hand, Poonam did arthroplasty, and Maharashtra is leading the way in diversity amongst all the states in India. So that is something important. It's a very big milestone in the journey of voice. To form ANMOL, that is the active network of Maharashtra orthopedic ladies, it's a first step. We should not get overjoyed just with the formation, but now the onus and responsibility is on us to make something really good out of this. And definitely pediatrics and hand will have enough ladies, but it takes a lot of courage to step into arthroplasty and spine. So I would encourage and want to use this platform to give a message to all the women watching out there, is that no branch in orthopedics is going to be difficult for you if you really make up your mind, put a lot of hard work, and have the right mentors. So please continue doing that. We need more ladies even in sports, which Neha is already representing. And I think the only specialty which we don't really have amongst the women in ortho is pelviacetabular. So I think that's what we all should aim to, that in future, voice has 350 members, and we should be having a lot of numbers in each and every specialty in orthopedics, and absolutely no limits. Just explore your horizons and just go ahead.
Thank you for the words.
Poonam, you are humble like your father, huh?
genetics. Genetics will always play a role.
चलो धन्यवाद मैडम, धन्यवाद चलो.
Congratulations everyone. Bye-bye.
I would like to take a screenshot.
See you in September.
Let's take a screenshot.
Yes, sir.
Yeah,
Okay.
quickly, whoever is there, everybody switch on your screens and let's take a screenshot. And let's thank all the audience for joining us in. I know that several of them are watching and several good seniors are watching us today. Thank you.
Okay, thank you very much.
Thank you.
Bye-bye.
Bye.
Well done, huh? Very, very good.
Neha, I
Hopefully
would like to congratulate you. You have a very cheerful and enthusiastic presence.